Thank you, Janice. I think we could have cut that one a little shorter. I'll have to figure that out. Look, I'm really honored to be here, and I'm just going to pull up my slides here really quickly. And obviously, I'm not allowed to theoretically call it Suboxone 101, as it's supposed to be buprenorphine naloxone, but hopefully we can all go with it because it sounds a little bit better when we call it Suboxone. Again, this is a little bit more dedicated to healthcare providers, but also really important for people living with pain to really kind of understand where buprenorphine naloxone comes from. Some minor conflict of interest. I've done some speaking and planning with Master Clinician Alliance in developing programs around buprenorphine naloxone. I also have several clinical trials with Health Canada, the Canadian Health Network, Alberta Innovates, and CIHR. And as mentioned, I'm the recent co-founder and chief medical officer of the Newly Institute. What's really important today is I have 30 minutes, so we're not going to be discussing mental health or recovery from chronic pain, but this is the most important thing. Today, we're just going to make a quick run through one medication that is in no way the answer to anything, nor is any other single medication when we're talking about chronic complex illness. As an introduction, we know that chronic pain is quite significant around the world. We can call it chronic, we can call it persistent. It depends on where you're looking. But the point being, somebody who has pain that is persistent in their life, sometimes it fluctuates, sometimes it doesn't. About 20% of the entire population, no matter where you're at, whether you're in Australia, Denmark, Europe, Canada, the United States, we see similar numbers over and over of just under 20% of the population living with chronic or persistent non-cancer pain. So how many does that really mean? Well, in Canada, it's about 7.6 million people. In the United States, about 66 million people. In Australia, it's about 5 million. And around the world, this represents approximately 1.6 billion people who have persistent and chronic pain. These are major, major numbers around the world. When we look at a review of different medications, there are so many, but today we're going to look at buprenorphine naloxone. And now here's the big question: can buprenorphine naloxone work in the treatment of chronic pain? Well, let's remember where buprenorphine comes from. It was developed as a pain medication for people who are living with cancer. And so people with cancer pain were the first people who were trialed for the treatment with buprenorphine naloxone or buprenorphine as a sublingual medication. And the outcomes were quite significant, showing significant improvement in pain in comparison to other medications. That was back in 1979. Now, more recently, in the early 2000s, Dr. Jonathan Deitch and his team looked at the conversion of opioids that were full agonists to buprenorphine, and we saw significant reduction in pain at about 20 to 30% overall reduction just in a rotation of a medication, well beyond almost any other medication out there. Now, you can notice people on higher doses of opioids didn't seem to have the same outcomes, but he also noticed in his paper that during a power calculation, it wasn't enough people in that group to really make a determination whether or not it was working. So he redid the study with higher doses. And again, we saw these massive reductions in pain from 8s to 5s, from 7s to 4s, huge reductions that are incredible. When we look at addiction and pain, when we try to understand addiction and pain, obviously just calling people and saying, are you addicted to anything? People are just going to say no. In the POINT study under Degenhardt, they actually looked at interviewing each individual patient in the study and going through an assessment of addiction. And what they found is approximately 20% or 1 in 5 people who are on chronic opioid therapy, living with chronic pain, also met the DSM-5 diagnosis of a pharmaceutical opioid use disorder. And that was removing tolerance and withdrawal, as that is going to occur in anyone who is on an opioid for long term. So how do we initiate this medication? If it seems like it's a good medication, this is one of the biggest barriers, is trying to start the medication. And that often runs into a lot of problems. Now, for academics, you can read in the Canadian Journal of Pain. We published on this just this year, it was last year, I guess, and looking at using home induction protocols during COVID, as we didn't think bringing people into clinic was a good idea. In my opinion, bringing people into clinic in withdrawal is never a good idea. And it turns out the data agrees with us. So our home initiation protocol is really designed to improve patient outcomes. So people can just start this medication at home. It's pretty simple. It's 12 hours after your short acting, 24 hours after your long acting. It's a slow initiation, combining kind of a microinduction and a traditional induction protocol. This is part of the publication, but basically you stop your long-acting medication in the morning, your short-acting medication before you go to bed. You wake up in the morning and you wait as long as you can before you can take another medication, at least 12 hours after your short acting and 24 hours after your long acting. So you take your last long acting at 9 in the morning, your last short acting at 9 o'clock at night, and you would start buprenorphine naloxone at 9 o'clock in the morning, taking one tablet every hour, 1 2 milligram tablet every hour until you feel good. 16 milligrams on day 1, which many people will be stable on that dose. And if you need more, you would take the 16 on day 2 and add an extra 2 milligrams every hour until stable. This innovative process really came to fruition by working with fellows and residents and watching them try to explain to patients about, well, I want you to take 2 milligrams here and then 4 milligrams and wait 2 hours, and maybe 4 hours, then maybe take another 2 milligrams. And I sat in the room realizing the person who was going to start the medication had no idea what was going on. The resident or fellow physician, I don't think really had any idea going on. And I was sitting there really having no idea when I was supposed to decide when the patient was supposed to take the medication. And so we just decided, let's make it simple. Take 2 milligrams every hour until you feel good. It is as simple as that. We prescribe a couple of days worth of medications. We call on day 2, find out what dose they got to, and then prescribe that on a weekly basis after that, often dispensing up to a month at a time. In no way, shape, or form should anybody be going to the pharmacy once a day to pick up this medication unless it's absolutely indicated, i.e. you have nowhere to store the medication, you don't have a home to store the medication in, whatever some of those cases may be. Otherwise, it should all be dispensed on a weekly or monthly basis. We often use the SOWS, which sounds terrible and really is a weird name, but it is the Subjective Opioid Withdrawal Scale. The reality is the amount of times I've done this with people, everyone knows when they're in withdrawal. I ask them to stay as long as they can, and then they can initiate at that point. This protocol really is about improving the outcomes of individuals. As mentioned, you can look at the study. What's really interesting is we've kind of really focused on microinductions and making it easy. This is a recent study by Gail D'Onofrio, who really is the guru of initiating buprenorphine naloxone in emergency departments. And they did macro dosing. So starting someone on 4 to 8 milligrams on their first dose, and then quite simply giving them 16 to 24 milligrams on their second dose and discharging at that time. Really no need for this long, slow process. And when they looked at precipitated withdrawal, there were similar rates as in normal inductions or microinductions, really next to nothing. So a really incredible protocol. There's some groups across the country, the Timmins group doing an incredible job doing this exact same thing, where the initiation can all be done in one day, and then that individual will be feeling much better after that. And an important process that we're still learning how to initiate, and that is a huge barrier to access for people who are living with pain and looking for a better way. Remember, buprenorphine may be a great treatment for opioid-induced hyperalgesia as well. The microinduction method is something that also works. This is kind of a bridging method. The reason being is that buprenorphine naloxone is a partial agonist whereas other opioids are full agonists. Now, we used to think that means that buprenorphine can't provide good pain treatment, but I mean, really, that was just folklore. We don't need a full agonist, considering the affinity that buprenorphine has to the receptor, meaning it's highly magnetic to that receptor, and it stays there for a long period of time, not just popping in and popping off. But what that means is, because it's a partial agonist, we want to replace each receptor at a time. If we just suddenly give you a partial agonist from a full agonist, it'll almost be like hitting a car when you're going 200 miles an hour, a car in front of you that's going 100 miles an hour, like hitting a brick wall. We want to slowly change each of those receptors one at a time to reduce any negative effects, so that you just do one receptor at a time. And that really improves the outcomes with these microdosing and bridging effects. The key is that 7 days or 10 days or 12 days, you simply come off of one medication and start the other medication. This whole kind of microdosing, or what was called the Bernese Method, really had addiction medicine up on arms for a couple of years, as it was initially presented as a poster at a conference in Europe. And it was then in about 2016 when that poster was published in the peer-reviewed literature. This is actually Dr. Annabelle Mead's kind of protocol, which is, we always try to bubble pack it. We simply start at a very low dose, 0.5 or 0.25 milligrams. It'll not be enough to displace or cause any precipitated withdrawal. And then you just slowly increase over time till you get to about day 9. And then you can do the same initiation that we talked about before, 1 tablet every hour until you feel good. And then that will be your dose every day. The other nice thing about buprenorphine, it's very long acting. You only need to take it once a day, and it works extremely well in doing so. Now, what are some other uses of buprenorphine? One of them is deprescribing. Now, it's important to remember, deprescribing is something that is patient-led. It is a voluntary process where someone who's taking opioids and the physician work together, or the nurse practitioner or other practitioner work together to support someone coming off. Tapering is something we do to someone. Deprescribing is something we do with someone. Now, there's lots of evidence in dose reduction and discontinuation of long-term opioid therapy. In this study back in 2017, they looked at 67 studies with a pretty large sample size. And in that sample size, those were considered the good studies. In those good studies, what we saw is that pain severity did not get worse with a reduction. In some studies, we did see an increase in pain, and those were not very well done studies. And then in the poor studies, we shouldn't even really talk about them. Now, there's a bit of a conundrum here. We don't force people to taper. This concept of doing something because we're supposed to do things, or doing something to people, is false. We do it with people. And Dr. Jane Ballantyne and Dr. AJ Manhapra have published on this on more than one occasion. Forced tapers can make things worse, can increase pain, can increase anxiety, can increase depression, can increase insomnia, can really make things worse for people, and cause much worse outcomes, as they're often done too quickly and without patient consent. We also know in this study that it actually increases the risk of death. And that's an important piece as well to understand, that when we force people off of their medications, often people become so unwell, they will end up trying to get them elsewhere, or their mental health will worsen so much that they will have to end up struggling and having much higher morbidity and mortality. So we know we should not, in primary care, be forcing people off of their medications. And even more fascinating is that it's been shown we need to do this in an interdisciplinary protocol. We need to do it with addiction medicine and with good mental health supports, as there's a lot of difficulties. And yet somehow this paper got published saying we shouldn't actually even have deprescribing programs at all, and we should just leave it alone. Yet we know we can improve mental health, we can improve pain, we can improve outcomes. We have good data. We have a deprescribing program in Calgary that was running that showed the same thing. this really didn't make any sense to anyone who is an expert in this field. And in fact, one of the coolest things I'm looking forward to is this study comparing short-acting versus long-acting opioids in the treatment of pain. Certainly in my anecdotal experience, we often rotate a lot of people off of their long-acting and go to short-acting, and we get much better pain outcomes by doing so, as the long-acting simply increases tolerance and the short-acting has good effect on treating pain. How do we deprescribe? Well, first of all, any sort of protocol is probably not going to work. This study showed the same thing, that individualized starting dosages and changes were very important. And following a patient-centered or person-centered process has much better outcomes and can be done in outpatient programs for those who decide to try to come off all their meds and unrelease the shackle of the pharmacy. Some clinical pearls: always do it with consent. Always stabilize first. Don't start tapering someone who is in severe pain. That's not going to help unless opioid-induced hyperalgesia is indicated or suggested. Always start tapering the long-acting. It doesn't do much except increase tolerance and make the short-acting less effective. Monitor the short-acting effect and taper sometimes as their tolerance comes down. That short-acting can become dangerous. You can pause, you can stop, you can even sometimes increase the dose as you're going based on what's going on for each individual. And make sure you're doing it slow. Reductions of 2 to 5% every 4 to 6 weeks, not 10%. The real advantage is that rotating over to buprenorphine naloxone can make those tapers a lot easier. It's a partial agonist. It's designed to create homeostasis, which means after just a couple of months, tapering becomes really easy. And then we have some of these more novel approaches with the subcutaneous injectable, where we can do a 1 injection over 5 months and then just stop it. And the data shows those people have no withdrawal symptoms at all and are completely off medications for life, which is pretty impressive. The Subcutaneous medication, or the long acting, goes into the subcutaneous fat. It becomes a little bleb and it slowly releases buprenorphine over the month. And once you get to continuous steady state, which takes 5 months, you can just stop it and be done with it. Another option is a subdermal implant, which literally are just some rods that go under the arm. Those rods would last for 6 months. And you can do 2 of those or even just 1 of those and allow someone to come completely off with no concerns or negative outcomes. So I will pause there and open it up for any sort of questions, and leave it up to the moderator to determine what's next.
Thanks, Rob. That was speedy. And it's so nice to hear that you are passionate. And this is something that you really are enjoying to do, and to actually provide helpfulness to our patients and our healthcare providers alike. So I know weaved throughout your conversation, you were talking about it's pretty easy, it's simple. We can actually do this in a way that's manageable. So sometimes when we start new ideas, when we approach something, it can be daunting. And it could be for both person who's approaching this and for healthcare provider. So when we start that for the first time, it can be really overwhelming at times. So you shared some simple strategies to initiate and maintain. So I'm wondering if you could provide some encouragement and advice, for someone who's starting, and the engagements that you're having with your patients. So both from the point of view of working with, not forcing, working with the patient or with the person with lived experience with pain, and we're working with physicians as well.
Yeah, I mean, I think that when we think about people living with pain, obviously, this is a really scary concept. There's a lot of false information out there, like this doesn't work, it won't help you. That in and of itself is a scary process for someone to go into. Yet in the experiences of many people who work in this field, we've seen incredible outcomes, and people do much, much better with their pain, with their mental health, with their sleep, with their appetite, even getting their libido back in many cases. And so really showing an improvement in quality of life. So a lot of it has to be really talking to the experts. We have an excellent video that we've created and is designed by people who have gone through deprescribing and some of them who have used buprenorphine to help them get off. And I think that's an important thing, is really having peers that can be available and someone to talk to. And so the Alberta Talks Pain is a great peer-led initiative that has some people that have been through the protocol. So feel free to reach out to them. On the physician side and the practitioner side, it is daunting and it is scary. In many cases in Alberta, for sure, there's a rapid hotline, which really is access on a telephone to a specialist to talk about how to initiate it. This is run by Dr. Nathaniel Day, who's really amazing, who does the one-day initiation protocols. Fantastic to walk through and teach you. In the Calgary zone, our RAM program does a lot of these with Specialty Link, a lot of these telephone consults to help people in understanding how to initiate and how to start. But you know what? Go to an Indivier dinner, and I know that's a swear word, and that's not even someone who's one of our sponsors, but they do a lot of this education. Find some education in your province. In Alberta, we have some great ones. BC has some great ones, as does Ontario and many of the other provinces. And follow suit with just educating yourself. It's easier than a lot of the diabetic medications, and certainly safer than a lot of the opioids we're prescribing today.
Wonderful, thank you. And so we're getting some questions from our attendees, so I'm just going to continue to ask them of you.
Of course.
So someone was asking, along the lines of what you were speaking about, just wondering how to address the social and emotional distress with tapering people off opioids in general, or for that matter, switching to partial agonists.
Yeah, so it should always be done with good psychosocial support. So when we were running this program, we had a trauma therapist, a psychologist, who, we were doing some groups where we'd learn about our emotions, how our emotions are affected. We'd learn about distress and how when we get distressed, we tighten up, which is horrible for people who are living with pain. So learning skills to calm that distress. And obviously, we've heard this a few times today. People who live with pain are much more susceptible to PTSD. So we need to treat the PTSD, and that doesn't mean informed care. Informed care is fantastic in a surgical program or in an OB program where, mental health isn't a main piece to that, although we're learning in transitional pain, it's a huge piece to it. But in programs where you're actually treating things like chronic pain where PTSD is highly prevalent, in addiction where it's highly prevalent, and in mental health programs, it shouldn't be trauma-informed care. We should have trauma-trained therapists, and we should be treating the underlying trauma. PTSD is not palliative, it's treatable. And same thing, that emotional dysregulation, when we start lowering those opioids, remember that opioids also dampen our emotional responses and our social connectivity. And suddenly all that stuff starts coming back. You're going to need good therapists that can support and work with those individuals. And I know at the TAPME clinic in Toronto, that's a big piece at their transitional service where they do use a lot of buprenorphine naloxone. It is always the same way as what we were doing here in Calgary, interconnected with strong psychologists that can support the process.
You bring up a really important point. It's that holistic coming together multidiscipline approach. And so when I think of peer-to-peer support and I think of the mentor and the mentee role, how have you been able to mentor and how have you been able to be available? Because I know you're very busy in your practice. How have you been able to be available and share your information to physicians, family doctors, and how has that worked well?
Well, I've been lucky enough, and Alberta Health Services has been supportive. We developed a lot of training programs, including the opioid dependency training program, the deprescribing training program, which was actually put together and developed with people with lived experience who have gone through a deprescribing program. So really trying to increase the virtual training programs out there for people, as it's impossible for one person or even a small subset of people who have expertise in this area to do everything. The Alberta College of Family Physicians Collaborative Mentorship Network is another really awesome program, and we're seeing mentorship networks now East Coast that's really just started, and throughout the rest of Canada and really the rest of the world, as you heard in the last segment. And these mentorship programs are really important, where you can talk to an expert who's done this many a times and can walk you through it. And to be really honest, the first time is the most anxiety provoking time for a practitioner. The second time is a walk in the park. And after that, it gets really, really easy. So in my opinion, I would say, find an expert, try to find a champion in your primary care network and team, and go for it. And I think that will be an important piece. And don't be afraid. It's such a safe medication, and the outcomes can be so positive for that individual. And always remember, and I always say this to people living with pain, remember, if it doesn't work, we'll put you back on your other dose. No problem. We don't have to worry about it. We're not going to keep you on it if it's not working. And for a certain population, around 5%, it does not work. And so we'll gladly rotate you back to a medication that will help.
And I just realized I was on mute. I was about to, that sometimes happens. I really see and I hear person-centered care. And I think that's something we're all striving to do with regards to that. So there comes a unique question from one of our attendees regarding social admissions in acute care nowadays. This person suggests that there are many social admissions in acute care nowadays post-withdrawal. So how appropriate, in your opinion, is it to provide the buprenorphine in large quantity for the people who are homeless or who could not go back to addiction, or who wish to not go back to that?
Well, I think it's super appropriate. I think, anything we can do to help support the safest medication we know in the opioid world is buprenorphine. So some people laugh, it should be like fluoride in the water, but in all reality, it's a pretty safe medication. I'm not really all that concerned about it. If that individual tells me I don't have a place to store it, sure, pick a pharmacy that you like and we'll get it dispensed at that pharmacy. It won't be the one I choose. I don't really care which one it is. Pick one that's close to you. And of course, good interdisciplinary care. And there's a big difference. Multidisciplinary is a bunch of boats on a lake. Everybody's doing their own thing, but they're all on one lake. We see these multidisciplinary clinics where you have a bunch of people working under one roof, but they don't really interconnect. A true interdisciplinary program is like a dragon boat on the water. Everybody's rowing in the same direction. You've got a leader, everybody's following suit. And that person that we're treating is the most important person in that piece. And so, having a good clinical pharmacist on board to help support that is a big piece. And then having good relationships with pharmacies throughout the community is important. But obviously, not just being connected to one and only one that really isn't about person-centered care anymore.
I think that's well said, because continuity of care and seamless care with our specialists, with our family doctors, with our community pharmacists, and thanks for the shout out to us pharmacists. I think it takes a village. And so really appreciate that. And I think even in the primary care field, that's where I work too, we sometimes just need to find those mentors and those mentees that can come together. And so I have one more quick question. This is more basic science. And then I'd love for you to share with us a bit more of your pearls, because we're running really early. So this last question is just centered around, is there a minimum or maximum amount of opioid to be taking to safely switch to Suboxone?
No, there are some great protocols for people on really high doses, but when it comes to prescribed opioids, it's one of the easier ones to rotate to. Often what I'll do is the long acting that's often taken 2 to 3 times a day. I'll give them the first dose in the morning, and we'll change the long acting throughout the day for short acting. And then they just got to take their last short acting before they go to bed. And then wait as long as you can in the morning. You don't need to go into a clinic. You don't need to sit in withdrawal and sweating and sick. That's inhumane, it's barbaric, and we don't do that kind of medicine. It's archaic. You can be at home, you push yourself as far as you can go without anything, and then you start the medication, and that's where you're going to get the best results. But it doesn't matter if you're rotating from methadone or from high dose oxycodone or hydromorphone. Fentanyl can get a little bit trickier, and often we suggest having a good expert to support the fentanyl rotation, because fentanyl is highly lipophilic, meaning it stores in different tissues in the body really easily. So when we think it's all gone, it's sometimes not all gone, and we can have some difficult reactions at those times. But outside of that, I've rotated people at extremely high doses, well over 1,000 milligrams of morphine a day. And I've rotated people who are just, taking 10 to 15 Percocets a day. So it doesn't matter the dose. It just matters that it's person-centered, interdisciplinary, with lots of supports. And people often do extremely well.
Wonderful. And I know there's a lot of good resources out there. Thank you for you and your other co-authors who have developed something in primary care practice that is easy to use and follow. I'm going to shout out to RX Files, fellow colleagues in Saskatchewan that also have great resources. So I'm going to land, like I said, with one last question. If you could provide us with some nuggets of information, maybe your clinical pearls, resources to access, because we do have about 5 more minutes. Would love to hear that, Rob.
Yeah, I think at the end of the day, just like, I'm asking primary care to find a champion, certain zones and provinces to find their champions, we also need peers to find their champions. So we've got a few. Again, I really do recognize Alberta Talks Pain and all the great work that Claudine Adlington has been doing. And there's a great resource there of support. There's many others in Alberta and in Canada that I really recommend being a part of. I think the other part is, as a practitioner, if you're taking a person-centered approach, you're not doing anything to anyone. You're working with people to help improve their quality of life, improve their pain, improve their mental health, and help them get their lives back. Recovery is real in pain. People don't need to always live in a horrible life. And it's up to us to help that process. And sometimes we get excellent outcomes. And in some cases, pain becomes palliative and difficult and a really unfortunate process. But we should be throwing everything we can at it, including good mental health supports. And I notice on the chat line, on the people with lived experience line, a lot of people are talking about that programs should be centered on mental health, should be centered on the person. And I couldn't agree more. When we developed the Deprescribing program, it was a voluntary program. If you didn't want to do it, you didn't have to do it. End of story. We did not allow anyone to refer to us saying, take over this patient's care and they're on opioids. No. That's not how we were working. We do need areas to protect patients. And we heard that today from Tracy Wasilak and the hard work we did a few years ago with patient support programs, Alberta Health Services, the College of Physicians and Surgeons of Alberta, the Pain Society of Alberta, the College of Family Physicians of Alberta, the Alberta College of Family Physicians, all of these people kind of came together with the primary care networks to really say, we're going to make sure nobody is abandoned, that people who are taking opioids for pain for many years, we're going to always stand by them. We're going to take care of them. Now we've got to figure out how to structurally and operationally do that. The Deprescribing program is no longer around, which is extremely unfortunate. We don't have the green zones that we're looking for people who lose a doctor, their doctor loses a license, or their doctor leaves the province and goes somewhere else. They need to know that they're always going to be supported. And these are the processes that we have to do moving forward. And so those are some of the important things. But the most important clinical pearl I got, do nothing without consent. Always do it together in a collaborative, person-centered relationship.
That's well said. And it's been a plum-pleasing joy to be able to collaborate with you. I know I've worked with you to support some of my folks within my clinic. So thank you for that. And thank you for being a patient champion. We really do appreciate that. And so with that said, I'm going to bring in Janice Ray. She's actually going to join us to provide us with a movement and wellness break. And I thank you, Dr. Tanguay, again, for your passion, your expertise, and we really appreciate hearing you always.
Thank you so much, Christelle and Janice, and to everybody who's watching. I hope this was beneficial for you, and always reach out if you need help. Thank you.